Varcarolis, Foundations of Psychiatric Mental Health Nursing, 8th edition. Chapter 4, Treatment Settings. Key terms and concepts. Assertive Community Treatment, ACT. Clinical Pathway, Community Mental Health Centers, Continuum of Psychiatric Mental Health Care. Decompensation, Elopement, Least Restrictive Environment, Milieu, Patient-Centered Medical Home, Prevention, Psychiatric Case Management, Recovery, Stabilization, Stigma, Triage. Obtaining traditional health care is fairly straightforward. For example, if you wake up with a sore throat, you know what to do and basically what will happen. It is likely that if you feel bad enough, you will see your primary care provider to be examined and maybe get a throat culture to diagnose the problem. If the cause is bacterial, you will probably be prescribed an antibiotic. If you do not improve in a certain length of time, your primary care provider may order more tests or recommend that you see an ear, nose, and throat specialist. Compared with obtaining treatment for other physical disorders, entry into the healthcare system for the treatment of psychiatric problems can be a mystery. Challenges in accessing and navigating this care system exist for several reasons. One reason is that we just do not have much of a frame of reference. We are unlikely to benefit from the experience of others because having a psychiatric illness is often hidden as a result of embarrassment or concern over the stigma or a sense of responsibility, shame, and being flawed associated with these disorders. You may know that when your grandmother had heart disease, she saw a cardiac specialist and had a coronary artery bypass. However, you may be unaware that she was also treated for depression by a psychiatrist. Seeking treatment for mental health problems is also complicated by the very nature of mental illness. At the most extreme, disorders with a psychotic component may disorganize thoughts and impede a person's ability to recognize the need for care. There is even a word for this inability: anosognosia. Major depression, a common psychiatric disorder, may interfere with motivation to seek care because the illness often causes feelings of apathy, hopelessness, and anergia, or lack of energy. Mental health symptoms are also confused with other problems. For example, anxiety disorders often manifest in somatic symptoms, such as racing heartbeat, sweaty palms, and dizziness, which could be symptoms of cardiac problems. Prudence would dictate ruling out other causes, such as physical illness, particularly because diagnosing psychiatric illness is largely based on symptoms and not on objective measurements such as ECGs and blood counts. Unfortunately, this necessary process of ruling out other illnesses often results in troublesome treatment delay. Further complicating treatment for mental illness is the unique nature of the system of care, which is rooted in the public and private sectors. The purpose of this chapter is to provide an overview of this system, briefly examine the evolution of mental health care, and explore different venues by which people receive treatment for mental health problems. Treatment options are presented in order of acuteness, beginning with those in the least restrictive environment. That is, the setting that provides the necessary care while allowing the greatest personal freedom. Background. Psychiatric care in the United States has its roots in asylums created in most existing states before the Civil War. These asylums were created with good intentions and a belief that states had a special responsibility to care for the quote-unquote insane. Effective treatments were not yet developed, and community care was virtually non-existent. By the early 1950s, there were only two real options for psychiatric care: a private psychiatrist's office or a mental hospital. At that time, there were 550,000 patients in state hospitals. A majority were individuals with disabling conditions who had become stuck in the asylums. The number of people in state-managed psychiatric hospitals began to decrease with the creation of Medicare and Medicaid during the 1960s Great Society reform period. Medicaid had an especially potent effect because it paid for short-term hospitalization in general hospitals and medical centers and for long-term care in nursing homes. It did not, however, cover care for most patients in psychiatric hospitals. These incentives stimulated development of general hospital psychiatric units and also led states to transfer geriatric patients from 100% state-paid psychiatric hospitals to Medicaid-reimbursed nursing facilities. In the 1999 Olmstead decision, the Supreme Court decreed that keeping people in psychiatric hospitals was unjustified isolation. The opinion of the court was that mental illness is a disability, that institutionalization is a violation of the Americans with Disabilities Act, and that all people with disabilities have a right to live in the community. These forces led to the creation of state and country-financed community care systems to complement and largely replace functions of the state hospitals. The population in state hospitals dropped dramatically, and many of these institutions were closed. The number of state psychiatric hospitals continues to be cut and has been reduced from 322 in 1950 to 195 in 2016. Related to the shift from hospital to community care were the pharmacological breakthroughs in the mid-20th century that resulted in dramatic changes in the provision of psychiatric care. The introduction of chlorpromazine or thorazine, the first antipsychotic medication in the early 1950s, contributed to hospital discharges. Gradually, more psychopharmacological agents were added to treat psychosis, depression, anxiety, and other disorders. Treatment provision expanded beyond specialties in psychiatry, as general practitioners began to feel more comfortable prescribing medication and managing symptoms. Our current system of psychiatric care includes outpatient and inpatient settings. Decisions for level of care tend to be based on the condition being treated and the acuteness of the problem. However, these are not the only criteria. Levels of care may be influenced by such factors as a concurrent psychiatric or substance use problem, medical problems, acceptance of treatment, social supports, disease chronicity, or potential for relapse. Continuum of care. What if you, your friend, or a family member needed psychiatric treatment or care? What would you do or recommend? Figure 4.1 presents a continuum of psychiatric mental health care that may help you make a decision. Movement along the continuum is fluid and can go in either direction. For example, patients discharged from the most acute levels of care, e.g. hospitalization, may need intensive services to maintain their initial gains. Failure to follow up with outpatient treatment increases the likelihood of rehospitalization and other adverse outcomes. Patients may also reverse direction on the treatment continuum. That is, if symptoms do not improve, professionals from a lower intensity service may refer the patient to a higher level of care to prevent decompensation or deterioration of mental health and hospitalization. Differences in characteristics, treatment outcomes, and interventions between inpatient and outpatient settings are identified in Table 4.1. Outpatient care settings. Primary care providers. Primary care providers are the first choice for most people when they are ill. But what about psychiatric symptoms? Imagine that you are feeling depressed, so depressed in fact that you are miserable and cannot carry out your normal activities. You recall that a friend who was depressed saw a psychiatrist, or was at a psychologist. But that seems too drastic. You do not feel that bad. Perhaps you are coming down with something like a cold or flu. After all, you have been tired, and you are not eating very well. You decide to visit your primary care provider, a general health care provider who may be a physician, an advanced practice nurse, or a physician assistant in an office, clinic, or hospital. This is not an unusual choice. Seeking help for mental health problems from primary care providers rather than from mental health specialists is common and similar to seeking help for most other medical disorders. This is especially true because most psychiatric disorders are accompanied by unexplained physical symptoms such as headaches, backaches, and digestive problems. Most people treated for psychiatric disorders will not go beyond this level of care and may feel more comfortable being treated in a familiar setting. Being treated in primary care rather than in the mental health system may also lessen the degree of stigma, self-perceived or societally, attached to getting psychiatric care. Disadvantages to being treated by primary care providers include time constraints, because a 15-minute appointment is usually inadequate for a mental and physical assessment. Additionally, primary care providers typically have limited training in psychiatry and may lack expertise in the diagnosis and treatment of psychiatric disorders. These professionals may refer people to specialty mental health care. Specialized psychiatric care providers. Most primary care providers feel comfortable in treating common psychiatric illnesses such as uncomplicated depression. However, they may feel less comfortable when suicide ideation is present or with more severe disorders such as schizophrenia. Specialized psychiatric care providers have an educational background and experience in care of psychiatric problems and mental health. These providers include psychiatrists, psychiatric mental health advanced practice registered nurses, nurse practitioners or clinical nurse specialists, psychologists, social workers, counselors, and other licensed therapists. Many primary care practices are partnering with specialty psychiatric providers who work in the same location, allowing for rapid access to care and effective triage and screening. Specialized care providers can provide numerous services. Psychiatrists can prescribe medications. Depending on the state, advanced practice psychiatric nurses and physician assistants can prescribe medications with some restrictions. Most specialized care providers are educated to use individual psychotherapy, talk therapy, and lead group therapy. These providers may have subspecialties, such as a provider who specializes in working with veterans with PTSD. How do you locate one of these specialized psychiatric care providers? One of the first steps is to inquire with a local care organization, such as a primary care office, hospital, clinic, or therapy practice. Other ways to find specialty care include asking peers, seeking help through support organizations, or contacting one's insurance company for a list of covered providers. Electronic searches are also good options. Reputable websites, particularly those with state or federal funding, can provide a wealth of information designed to point consumers in the proper direction. Reviews of the care provider on these websites can be helpful in making your decision. Patient-centered medical homes. Patient-centered medical homes, PCMHs, or primary care medical homes receive strong support from the Affordable Care Act of 2010 under President Barack Obama. These health homes were developed in response to fragmented care that resulted in some services never being delivered while others are duplicated. The focus of care is patient-centered and provides access to physical health, behavioral health, and supportive community and social services. Patients are provided with a range of support for preventative care, acute care, chronic disease management, and end-of-life issues. According to the Agency for Healthcare Research and Quality, these homes have 5 key characteristics. 1. Patient-centered care is relationship-based with the patient and takes into account the unique needs of the whole person. The patient is a core member of the team. 2. Comprehensive care. All levels, preventative, acute, and chronic, of mental and physical care are addressed. Physicians or advanced practice nurses lead teams and include nurses, physician assistants, pharmacists, nutritionists, social workers, educators, and care coordinators. 3. Coordination of care. Care is coordinated with the broader health system such as hospitals, specialty care, and home health. 4. Improved access. Patients are not limited to Monday through Friday from 9 a.m. to 5 p.m. to get the care they need. In addition to extended hours of service, these homes provide email and phone support. 5. Systems approach. Evidence-based care is provided with a continuous feedback loop of evaluation and quality improvement. The treatment of psychiatric disorders and mental health alterations can be addressed as part of a comprehensive approach to care. Electronic communication, e.g. follow-up emails and reminders, and record keeping are viewed as essential aspects of this process. Community mental health centers. Beginning in the 1960s, patients with severe mental illness were diverted from state-funded psychiatric hospitals to federally funded community mental health centers. Since that time, these centers have become the mainstay for those who lack funding for mental health care. They offer free or low-cost sliding scale care. Community mental health centers provide emergency services, community/home-based services, and outpatient services across the lifespan. Common treatments include medication prescribing and administration, individual therapy, psychoeducational and therapy groups, family therapy, and dual diagnosis, mental health and substance abuse treatment. A clinic may also be aligned with a structured program that offers rehabilitation, vocational services, and residential services. Some community mental health centers have an associated intensive psychiatric case management service to assist patients in finding housing or obtaining entitlements. Community mental health centers also utilize multidisciplinary teams. Psychiatric mental health registered nurses are key members of these teams. Nurses provide medication administration and mental health education to help individuals continue treatment and reach an optimal level of functioning. Advanced practice psychiatric registered nurses hold a significant role in community mental health centers by conducting patient intakes, psychotherapy, and medication management. Psychiatric home care. Psychiatric home care is a community-based treatment modality. Medicare requires that 4 elements be met in order for these services to be reimbursed. 1. Homebound status of the patient. 2. Presence of a psychiatric diagnosis. 3. Need for the skills of a psychiatric registered nurse. And 4. Development of a plan of care under orders of a physician or advanced practice registered nurse. Reimbursement and guidelines for psychiatric home care by other payers besides Medicare vary greatly. Homebound refers to the patient's inability to leave home independently due to a physical or mental condition. Patients may be referred for psychiatric home care after an acute inpatient hospitalization episode of care or to prevent hospitalization. Medicare allows 2 groups of healthcare providers to be involved in psychiatric home care. They are social workers with master's degrees and psychiatric registered nurses. Social workers provide counseling and medical social services, such as linking people with necessary health care and services. Psychiatric registered nurses provide evaluation, therapy, and teaching. Typically, the nurse visits the patient 1 to 3 times per week for a limited period of time. By going to the patient's home, the nurse is better able to address the concerns of access to services and adherence to treatment. Nurses working in the home have to be especially adept at assessing anxiety, agitation, and the potential for violence in this non-clinical setting. Assertive community treatment. ACT is an intensive type of case management developed in the 1970s. This treatment was in response to the hard-to-engage community living needs of people with serious, persistent psychiatric symptoms. Due to the severity of their symptoms, they are often unable or unwilling to participate in traditional forms of treatment. As a result, this population has unnecessary and expensive repeat hospitalizations for services such as emergency room and inpatient care. ACT teams work intensively with patients in their homes or in agencies, hospitals, and clinics, whatever settings patients find themselves in. Creative problem solving and interventions are hallmarks of care provided by mobile teams. The ACT concept takes into account that people need support and resources after 5 p.m. Therefore, teams are on call 24 hours a day. ACT teams are multidisciplinary and typically composed of psychiatric mental health registered nurses, social workers, psychologists, advanced practice registered nurses, and psychiatrists. One of these professionals, often the registered nurse, serves as a case manager and may have a caseload of patients who require visits 3 to 5 times per week. An advanced practice registered nurse or a psychiatrist usually supervises the case manager. Length of treatment may extend to years until the patient is more stabilized or ready to accept transfer to a more structured site for care. Intensive outpatient programs and partial hospitalization programs. Intensive outpatient programs, IOPs, and partial hospitalization programs, PHPs, function as intermediate steps between inpatient and outpatient care. The primary difference between the two groups is the amount of time that patients spend in them. Both groups tend to be Monday through Friday, but IOPs are usually half a day, while PHPs are longer, about 6 hours, because they are partially hospitalized. They provide structured activities, along with nursing and medical supervision, intervention, and treatment. These programs tend to be located within general hospitals, in psychiatric hospitals, or as part of a community mental health. A multidisciplinary team facilitates group therapy, individual therapy, other therapies, e.g. art and occupational, and pharmacological management. Coping strategies learned during the program can be applied and practiced in the outside world and later explored and discussed. Patients admitted to IOPs and PHPs are closely monitored in case of need for readmission to inpatient care. Other outpatient venues for psychiatric care. Mobile mental health units have been developed in some service areas. In a growing number of communities, mental health programs are collaborating with other health or community services to provide integrated approaches to treatment. A prime example of this is the growth of dual diagnosis programming in both mental health and substance abuse disorder clinics. Telephone crisis counseling, telephone outreach, and the internet are being used to enhance access to mental health services. Although face-to-face interaction is still preferred, the new forms of treatment through technology, such as telepsychiatry, have shown immense patient satisfaction and no evidence of complications. Access and overall health quality and outcomes are expected to improve as models of care that include telehealth and other innovative practices advance. Emergency care. Patients and families seeking emergency care range from the worried well to those with acute symptoms. The primary goal in emergency services is to perform triage and stabilization. Triage refers to determining the severity of the problem and urgency of a response. Stabilization is the resolution of the immediate crisis. Emergency department care often provides a bridge for the community to more intensive psychiatric services, such as inpatient care. Individuals may seek emergency care voluntarily. However, there are times when family, friends, treatment providers, schools, emergency medical personnel, or even law enforcement may suggest or require an individual to undergo emergency evaluation. When emergency evaluation and stabilization are needed, psychiatric clinicians, including psychiatric mental health nurses, will determine the correct interventions and level of care required. Refer to Chapter 6 for a more detailed discussion about involuntary treatment. Emergency psychiatric care varies across the nation due to differences in state mental health system design, access to care, and workforce. Despite these differences, emergency psychiatric care can be categorized into three major models. One comprehensive emergency service model is often affiliated with a full-service emergency department in a hospital or medical center setting. Typically, there is a dedicated clinical space with specialty staffing. Psychiatric mental health nurses, psychiatric technicians, mental health specialists, social workers, mental health counselors, and psychiatrists generally make up the multidisciplinary workforce. The concepts of triage and stabilization are incorporated into the individualized care plan for each patient. 2. Hospital-based consultant model utilizes the concepts of the comprehensive model by incorporating triage and stabilization. However, there is generally no dedicated clinical space or comprehensive separate staffing. Psychiatric clinical staff members are assigned to a specific hospital and are on-site or on-call, serving as part of the emergency department staff. Psychiatric clinicians manage emergency psychiatric evaluations as requested. Clinicians complete a level of care assessment, attempt to stabilize patients, and arrange for discharge or transfer. The emergency department staff maintain responsibility for all immediate care needs. 3. Mobile crisis team model is considered for stabilization in the field. The teams meet face-to-face with the person in crisis to assess and de-escalate the situation. While the teams vary in composition, psychiatric mental health nurses, social workers, and counselors, in collaboration with a psychiatrist and or an advanced practice nurse often make up the care team. Prevention in outpatient care. A distinct concept in the healthcare literature is that a treatment based on a public health model that takes a community approach to prevention. Primary, secondary, and tertiary prevention are levels at which interventions are directed. Primary prevention occurs before any problem manifests and seeks to reduce the incidence or rate of new cases. Primary prevention may prevent or delay the onset of symptoms in genetically or otherwise predisposed individuals. Coping strategies and psychosocial support for vulnerable young people are effective interventions in preventing mood and anxiety disorders. Secondary prevention is also aimed at reducing the prevalence of psychiatric disorders. Early identification of problems, screening, and prompt and effective treatment are hallmarks of this level. While it does not stop the actual disorder from beginning, it is intended to delay or avert progression. Tertiary prevention is the treatment of disease with a focus of preventing the progression to a severe course, disability, or even death. Tertiary prevention is closely related to rehabilitation, which aims to preserve or restore functional ability. In the case of treating major depression, the aim is to avoid loss of employment, reduce disruption of family processes, and prevent suicide. Outpatient psychiatric nursing care. Psychiatric mental health nursing in the outpatient or community setting requires strong problem-solving and clinical skills, cultural competence, flexibility, solid knowledge of community resources, and comfort in functioning more autonomously than acute care nurses. Patients need assistance with problems related to individual psychiatric symptoms, family and support systems, and basic living needs, such as housing and financial support. Psychiatric mental health nurses can be leaders in transforming an illness-driven and dependency-oriented system into a system that emphasizes recovery and empowerment. Nurses are adept at understanding the system and coordinating care. Further, nurses are respected members of the interdisciplinary team. They serve not only in lead clinical roles, but also as advocates for the inclusion of patient-centered and trauma-informed care models. The role of the outpatient or community psychiatric mental health registered nurse ideally includes service provision in a variety of these treatment settings. For example, psychiatric needs are well known in the criminal justice system and the homeless population. Individuals suffering from a mental illness tend to cycle through the correctional systems and generally comprise 50% of the incarcerated population. And from that number, 20% have a serious mental illness. The nurse's role is not only to provide care to individuals as they leave the criminal justice system and re-enter the community, but also to educate police officers and justice staff in how to work with individuals entering the criminal system. Table 4.2 describes the educational preparation for a variety of outpatient and community roles. Promoting recovery and continuation of treatment. In the not-too-distant past, treatment for mental illness consisted of patients being told what medications to take and what treatments to accept. Good patients were those who were compliant. A newer model of recovery promotes self-improvement in care. Recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Nurses are real assets in supporting patients in the recovery process, especially with medication management. Nurses are in a position to help the patient recognize side effects and be aware of interactions among medications prescribed for both physical illness and mental illness. This knowledge increases the individual's ability to self-advocate. Patient-family education and behavioral strategies in the context of a therapeutic relationship with the nurse promote adherence with a medication regimen. Patient-centered care, also referred to as person-centered care, supports values in the recovery model. It is respectful and responsive care that incorporates patients' preferences, needs, and values. This concept is essential for ensuring that the patient wishes and values are the guiding principle for care management and shared decision making. Inpatient care settings. Hospitalization is available for the treatment of acute symptoms or safety concerns for patients with mental disorders and emotional crises. In fact, 2.4 million adult patients were treated in hospitals in 2014 with a mental illness. The top 5 mental health diagnoses treated were mood disorders, substance use disorders, neurocognitive disorders, anxiety disorders, and schizophrenia. Admission is commonly reserved for those people who are suicidal, homicidal, or extremely disabled and need acute care. Crisis stabilization/observation units. Care models that prioritize rapid stabilization and short length of stay have become more prevalent in medical and psychiatric settings. Overnight short-term observation, often 1 to 3 days, are designed for individuals who have symptoms that are expected to remit in 72 hours or less. This observation is also helpful for individuals who have a psychosocial stressor that can be addressed in that time frame, maximizing their stability and allowing them to rapidly return to a community treatment setting. General hospital and private hospital. Acute care hospital psychiatric units tend to be housed on a floor or floors of a general hospital. Private psychiatric hospitals are freestanding facilities. As noted, the dramatic growth of acute care psychiatric hospitals and hospital units is the result of a shift away from institutionalization in state-managed hospitals. Since that time, reduced reimbursement, increased managed care, enhanced outpatient options, and expanded availability of outpatient and partial hospitalization programs have resulted in the steady decline of these facilities. State hospital. Although the quality of care in state hospitals has improved dramatically, today's state-operated psychiatric hospitals are an extension of what remains of the old system. The clinical role of state hospitals is to serve the most seriously ill patients. However, this role varies widely, depending on available levels of community care and on payments by state Medicaid programs. In some states, these hospitals primarily provide intermediate treatment for patients unable to be stabilized in short-term general hospital units and long-term care for individuals judged too ill for community care. In other states, the emphasis is on acute care that is reflective of gaps in the private sector, especially for the uninsured or for those who have exhausted limited insurance benefits. In most states, the state hospitals provide forensic, court-related, care and monitoring as part of their function. The state or county system also advises the courts as to defendants' sanity who may be judged to have been so ill when they committed the criminal act that they cannot be held responsible but require treatment instead. These judgments are not guilty by reason of insanity, NGRI. One tragic example is that of Andrea Yates, the Texas woman who in 2001 drowned her 5 young children under the delusional belief she was saving them from their sinfulness. She was found NGRI and was committed to a Texas state psychiatric facility. Considerations for inpatient care. Entry to acute inpatient care. Some patients are admitted directly to inpatient care based on a specialized care provider or primary care provider referral. However, the majority of patients receiving inpatient acute psychiatric care are admitted through an emergency department or crisis intervention service. Of the 12 million emergency department visits in the United States, nearly 13% are due to mental health and/or substance use conditions. Patients may be admitted voluntarily or involuntarily. Units may be unlocked or locked. Locked units provide privacy and prevent elopement, leaving before being discharged, also referred to as being away without leave or AWOL. There may also be psychiatric intensive care units, PICUs, within the general psychiatric units to provide better monitoring of those who display an increased risk for danger to self or others. Rights of the hospitalized patient. Patients admitted to any psychiatric unit retain rights as citizens, which vary from state to state, and are entitled to certain privileges. Laws and regulatory standards require that patients' rights be provided in a timely fashion after an individual has been admitted to the hospital, and that the treatment team must always be aware of these rights. Any infringement by the team during the patient's hospitalizations, such as failure to protect patient safety, must be documented, and actions must be justifiable. All mental health facilities must provide a written statement of patients' rights, often with copies of applicable state laws attached. Box 4.2 provides a sample list of patients' rights. Teamwork and collaboration. Psychiatric mental health nurses are core members of a team of professionals and non-professionals who work together to provide care. Box 4.3. The team, including the patient, generally formulates a full treatment plan. The nurse's role in this process is often to lead the planning meeting. This nursing leadership reflects the holistic nature of nursing, as well as the fact that nursing is the discipline that is represented on the unit at all times. Nurses are in a unique position to contribute valuable information such as continuous assessment findings, the patient's adjustment to the unit, any health concerns, psychoeducational needs, and deficits in the patient's self-care. Additionally, nurses have an integral function to facilitate a patient's achievement of therapeutic goals by offering education and support in an individual or group format. Ultimately, the treatment plan will be the guideline for the patient's care during the hospital stay. It is based on goals for the hospitalization and defines how achievement of the goals will be measured. Input from the patient and family, if available and desirable, is critical in formulating goals. Incorporating the patient's feedback in developing the treatment plan goals increases the likelihood of the success of the outcomes. Members of each discipline are responsible for gathering data and participating in the planning of care. Newly admitted patients may find multiple professionals asking them similar questions to be extremely stressful or threatening. The urgency of the need for data should be weighed against the patient's ability to tolerate assessment. Often, assessments made by the intake team and the nurse provide the basis for care. In most settings, the psychiatrist or advanced practice nurse evaluates the patient and provides orders within a limited time frame. Medical problems are usually referred to a medical consultant service, often consisting of physicians and advanced practice nurses who assess the patient and consult with the unit clinical team. To provide standardization in treatment and improve outcomes, inpatient units use clinical pathways. These task-oriented plans detail the essential steps in the care of patients with specific clinical problems based on the usual and expected clinical course. These tools provide an essential link between evidence-based knowledge and clinical practice. The treatment plan is revised if the patient's progress differs from the expected outcomes. Clinical pathways result in decreased cost, length of stay, and complications while improving outcomes. Therapeutic milieu. Milieu is a word of French origin, mi, middle, and lieu, place, and refers to surroundings and physical environment. In a therapeutic context, it refers to the overall environment and interactions within the environment. Peplau, 1989, referred to this as the therapeutic milieu. It is an all-inclusive term that recognizes the people, patients, and staff, the setting, structure, and the emotional climate as important to healing. Regardless of whether the setting involves treatment of psychotic children, adult patients in a psychiatric hospital, substance users in a residential treatment center, or psychiatric patients in a day treatment program, a well-managed milieu offers patients a sense of security and promotes healing. Structured aspects of the milieu include activities, rules, reality orientation practices, and environment. Managing behavioral crises. Behavioral crises can lead to patient violence towards self or others and usually, but not always, escalate through fairly predictable stages. Staff members in most mental health facilities practice crisis prevention and management techniques. Training generally consists of a full-day course learning the skills to recognize and avoid crisis and de-escalate behavioral emergencies. Hands-on techniques, which are only used as a last resort, are also taught. At minimum, annual training is recommended to maintain competency. Some facilities have special teams of nurses, psychiatric technicians, mental health specialists, and other professionals who respond to psychiatric emergencies called codes. Each member of the team takes part in the team effort to defuse a crisis in its early stages. If preventative measures fail and imminent risk of harm to self or others persists, each member of the team participates in a rapid, organized plan to safely manage the situation. The nurse is most often the team's leader, not only in organizing the plan, but also in timing the actions and managing the concurrent administration of medications. Seclusion, restraint, and emergency medication are actions of last resort. The trend is to reduce or completely eliminate these practices whenever safely possible. The nurse can initiate such an intervention in the absence of a physician, in most places, but must secure a physician's order for restraint or seclusion within a specified time. Refer to Chapters 6 and 27 for further discussion and protocols for use of restraints and seclusion. The concept of trauma-informed care is a guiding principle for clinical interventions and unit philosophy and is addressed more comprehensively in Chapter 16. Safety. A safe environment is an essential component of any inpatient setting. Protecting the patient is essential, but equally important is the safety of the staff and other patients. Safety needs are identified and individualized interventions begin on admission. Staff members check all personal property and clothing to prevent any potentially harmful items, e.g. medication, alcohol, or sharp objects, from being taken onto the unit or left in their immediate possession. Some patients are at greater risk for suicide than others, and psychiatric mental health nurses are skillful in evaluating this risk through questions and observations. The Joint Commission, an agency that accredits hospitals, developed National Patient Safety Goals 2015, specific to specialty areas within hospitals to promote patient safety. Table 4.3 lists safety goals specific to behavioral health care. Centers for Medicare and Medicaid Services also emphasize safety and have identified several preventable hospital-acquired injuries for which they will not provide reimbursement. For example, they will not compensate healthcare organizations when a patient falls and fractures a hip, as nearly all falls are preventable. It is likely that other health insurance providers will also begin to limit payment for preventable injuries under the regulatory concept of pay for performance. Tracking patients' whereabouts and activities is done periodically or continuously, depending upon patients' risk for harming themselves or others. For patients with active suicidal thoughts, continuous in-person observation is essential because even checking on a patient every 15 minutes may not prevent a suicide that takes only several minutes. Monitoring visitation is an important aspect of patients' well-being and safety. Although visitors can contribute to patients' healing, visits may be overwhelming or distressing. Also, visitors may unwittingly or purposefully provide patients with unsafe items. Staff should inspect bags and packages. Sometimes, the unsafe items take the form of comfort foods from home or a favorite restaurant and should be monitored because they may be incompatible with diets or medications. Intimate relationships between patients are prohibited. There are risks for STDs, pregnancy, and emotional distress at a time when patients are vulnerable and may lack the capacity for consent. Unit design. The goal in designing psychiatric units is to provide a therapeutic and aesthetically pleasing environment while balancing the need for safety, since patients on inpatient psychiatric units may be at risk for suicide or violence. Full compliance with regulatory and accrediting bodies should be required for each clinical setting. Promoting an environment of safety and empowering patients to partner with clinical staff and take ownership of their own health and safety is critical. Safety precautions are taken into account in each area of the unit. For example, closets may be equipped with breakaway bars or hooks designed to hold a minimal amount of weight to prevent strangulation by hanging. Windows are locked and made of safety glass, and safety mirrors are typically used. Showers may have non-weight-bearing or non-looping design shower heads. Beds are often platforms rather than mechanical hospital beds, which can be dangerous because of their crushing potential, looping hazard, and cords. However, standard hospital beds may be indicated depending on patient physical health needs. Other important design elements on inpatient psychiatric units include doors that open out instead of in to prevent patients from barricading themselves in their rooms. Continuous hinges on doors rather than 3 butt hinges to prevent hanging risk. Furniture that is anchored in place with the exception of a desk chair to prevent their use as a weapon or barricade. Drapes that are mounted on a track firmly anchored to the ceiling rather than curtain rods. Mini blinds contained within window glass provide significantly more safety than those whose mounting are accessible. Plumbing fixtures that are boxed in. Inpatient psychiatric nursing care. Management of these acute care units ideally is by nurses who have backgrounds in psychiatric mental health nursing, preferably with advanced practice degrees. Staff nurses tend to be nurse generalists, that is, nurses who have basic training as registered nurses. Some registered nurses achieve national certification in psychiatric mental health nursing through the American Nurses Credentialing Center. The staff psychiatric registered nurse carries out the following nursing responsibilities: completing comprehensive data collection that includes the patient, family, and other healthcare workers, developing, implementing, and evaluating plans of care, assisting or supervising mental health care workers, e.g. nursing assistants, with or without additional training in working with people who have mental illnesses, maintaining a safe and therapeutic environment, facilitating health promotion through teaching, monitoring behavior, affect, and mood, maintaining oversight of restraint and seclusion, and coordinating care by the treatment team. Medication management is an essential skill for psychiatric nurses. In this specialty area, nurses often exert a strong influence on medication decisions. This influence is due to the continual observation of the expected interactive effects and adverse effects of medications, provides the data necessary for medication adjustment. For example, feedback about a patient's excessive sedation or increased agitation may lead to a decision to decrease or increase the dosage of an antipsychotic medication. A common misperception regarding psychiatric nurses is that because they just talk, they lose their skills for physical tasks, such as starting and maintaining IV lines and changing dressings. In fact, most psychiatric nurses provide some degree of physical care. Patients on psychiatric units are not limited to psychiatric disorders and often have complex healthcare needs. For example, an older adult male with brittle diabetes and a recent foot amputation may become actively suicidal. In this case, it is likely he will be transferred to a psychiatric unit where his blood glucose level will be monitored and wound care provided. Table 4.4 provides sample nursing diagnosis, outcomes, and interventions for patients during admissions to the acute care setting. Specialty treatment settings. Treatment options are available that provide specialized care for specific groups of people. These options include inpatient, outpatient, and residential care. Pediatric. Children with mental illness have the same range of treatment options as do adults, but receive them apart from adults in pediatric settings. Inpatient care may be necessary if the child's symptoms become severe. Parental or guardian, including the Department of Children and Families, involvement in the plan of care is integral so that they understand the illness, treatment, and the family's role in supporting the child. Additionally, hospitalized children, if able, attend school several hours a day. Geriatric psychiatric care. The older adult population may be treated in specialized mental health settings that take into account the effects of aging on psychiatric symptoms. Physical illness and loss of independence can be strong precipitants in the development of depression and anxiety. Dementia is a particularly common problem encountered in geriatric psychiatry. Treatment is aimed at careful evaluation of the interaction of mind and body and provision of care that optimizes strengths, promotes independence, and focuses on safety. Veterans Administration Centers. Active military personnel and veterans who were honorably discharged may receive federally funded inpatient or outpatient care and medication for psychiatric and alcohol or substance use disorders. One of the greatest challenges veterans face is dealing with the after effects of the traumas of active combat. During Civil War times, these late effects were termed soldier's heart. After World War I, soldiers had shell shock, and after World War II, it was termed battle fatigue. Currently, mental health services are being inundated by people suffering from PTSD. There is a prevalence of PTSD in the general population of about 7%, and nearly 14% for veterans of the wars in Iraq and Afghanistan. This creates a tremendous need for strong psychiatric services for this population. Forensic psychiatric care. Incarcerated populations, both adult and juvenile, have higher than average incidences of mental disorders or substance abuse disorders. Researchers estimate that there are more people with mental illness in prisons than in hospitals. Treatment may be provided within the prison system, where inmates are often separated from the general prison population. State hospitals also treat forensic patients. Most facilities provide psychotherapy, group counseling, medication management, and assistance with transition to the community. Alcohol and drug use disorder treatment. All the mental health settings that were previously described may provide treatment for alcohol and substance use disorders, although specialized treatment centers exist apart from the mental health care system. More than 22 million individuals aged 12 or older needed treatment in 2013 for illicit drug or alcohol use problems. Only 2.5 million received specialized care. This treatment is typically outpatient and includes counseling, education, medication management, and 12-step programs. Because alcohol detoxification and other substance withdrawal can be life-threatening, inpatient care may be required for medical management. And lastly, self-help options. Obtaining sufficient sleep, meditating, eating right, exercising, abstaining from smoking, and limiting the use of alcohol are healthy responses to a variety of illnesses such as diabetes and hypertension. As with other medical conditions, lifestyle choices and self-help responses can have a profound influence on the quality of life and the course, progression, and outcome of psychiatric disorders. If we accept the notion that psychiatric disorders are generally a combination of biochemical interaction, genetics, and environment, then it stands to reason that, by providing a healthy living situation, we are likely to fare better. If, for example, a person has a family history of anxiety and has demonstrated symptoms of anxiety, then a good first step, or an adjunct to psychiatric treatment, could be to learn yoga and balance the amounts of life's obligations with relaxation. A voluntary network of self-help groups operates outside the formal mental health care system to provide education, contacts, and support. Since the introduction of Alcoholics Anonymous in the early 20th century, self-help groups have multiplied and have proven to be effective in the treatment and support of psychiatric problems. Groups specific to anxiety, depression, loss, caretakers issues, bipolar disorder, PTSD, and almost every other psychiatric issue are widely available in most communities. Consumers, people who use mental health services, and their family members have successfully united to shape the delivery of mental health care. Nonprofit organizations, such as the National Alliance on Mental Illness, NAMI, encourage self-help and promote the concept of recovery or the self-management of mental illness. These grassroots groups also confront social stigma, influence policies, and support the right of people experiencing mental illness.